This is a good question. I think that I'm one of the most defenders of the freeze-all strategy. However, I don't defend the freeze-all for all of the patients. I really think that we need to individualize the patients that really benefit from this strategy, not only thinking about effectiveness, but also about safety of treatment. I'm really concerned that most of IVF centers around the world, Japan, United States, there are many centers that are performing the freeze-all strategy for all of the patients, and we don't have enough evidence that we are really benefiting these patients if we perform freeze-all for all of the patients. We also need an individualization. I think that this is the word in reproduction, individualization. We need to find the best treatment for each patient and not only perform one specific kind of treatment for all of the patients.
All right, sir. So, which stage or day of embryo is optimal for transfer?
Again, I think that we need to individualize. In theory, the blastocyst, we have higher implantation rates. We have probably with higher live birth rates. When we evaluate these studies, considering the cumulative live birth rates, there are no difference when evaluating cleavage and blastocysts. It seems that if we perform the embryo transfer in blastocysts, probably we will decrease the time to pregnancy. We will have a lower number of embryos to freeze. But it's not for all of the patients. I think that we need to have some criteria in day 3 to select the patients that really benefit to go to blastocysts, or if we need to perform PGS. But mainly in poor responders patients, when we have a few number of embryos, there's no reason to do that. We will not select the embryos. We just have the number of embryos that patients deserve, and there's no reason to perform blastocysts for all of the patients. We need to select the patients that really benefit from this strategy.
All right, sir. So, what is your opinion on using uterine relaxants before embryo transfer?
Uterine?
Relaxants.
It's difficult. There's no clear conclusion about this and specific study, a good study evaluating this strategy. It's not a routine for us to use this kind of strategy.
All right, sir. So, in a line, can you please talk about the importance of recombinant FSH?
Yeah. The recombinant, I totally agree with recombinant. As I presented, we have real different results, not considering the live birth or ongoing pregnancy, but what is really important is the number of oocytes and probably the number of embryos that we have. And these drugs, they are completely different. They are recombinant and urinary, they are completely different. And I can see that, I think that 4 or 5 years ago, the place that I work, we changed. Previously we have half and a half and recombinant and urinary. Nowadays we just use recombinant. And these results, the cumulative results and the number of oocytes, it's really completely different. And we have a lot of evidence that recombinant probably, we really know the dose that we are giving to our patients and probably the results. Considering the number of oocytes, this is really important, and we have more with recombinant.
Okay. So, have you been to India before?
No, that's my first time.
This is your first time.
First
so how
time.
has your experience been?
It's really wonderful. It was a short period here. I just arrived 2 days ago, and I'm going back to Brazil today night. But it's my first time. But I remember it for forever. I told to the audience that I'm sure that this is the first, but this will not be the last time.
Of course.
I don't know if I'll come back as a speaker or just for vacation, but for sure that I'll be back.
Awesome, sir. Sir, and what do you think about this entire conference, Genesis?
I really like this kind of conference, and I think that you really organize everything very well. These smaller events, when compared to the large events, probably it's possible to have a more interaction with the audience with the speakers. I think that it's really benefit for all of us, the speakers and also the audience. I really like, and Genesis is amazing.
So, what is your choice of protocol for hyperendurance responders?
In general, we select this group of patients. We need to think about efficacy and safety. When thinking about safety, in general, there are high responders. You need to use antagonist protocols, and I use recombinant for all of them. For all the patients, I use recombinant, and we don't need high dose of gonadotropin, in general 100 to 150 dose international unit for this group of patients, and the trigger with GnRH agonist. And most of these high responders in general, in our routine, we consider with over 15 or retrieved oocytes in general. In this group of patients, we perform the freeze-all. We think that we perform freeze-all in these high responders. We are probably decreasing the risk, not only decreasing the risk of OHSS, but also improving the endometrial receptivity for this group of patients.
Okay.
And for normal, again, antagonist, those range recombinant, those range from 150 to 225. In general, it's not necessary to perform the freeze-all. We published a study last month in JARC, Journal of Assisted Reproduction, considering the normal and suboptimal responders. In normal, 10 to 15 oocytes seems to have some benefit in performing freeze-all for these patients. For those patients that in general, mainly in our country, patients with lower than 10 oocytes retrieved, lower than 9 oocytes retrieved, fresh embryo transfer, it's really well. And we can select the best approach, the best trigger for this group of patients. In general, we perform dual trigger. We think that the addition of GnRH and HCG is really of benefit for these patients.
Okay. Sir, what is your view on fresh transfer versus FET in hyperresponders?
As I mentioned, I think that in hyperresponders, I think that this is the ideal group to think about the freeze-all and not perform the fresh embryo transfer to its group of patients. We don't need to delay so much time to perform, just freeze, and in the next cycle you can perform the embryo transfer. So I think that nowadays we can't have hyperstimulation in our patients.
All right.
It's totally iatrogeny nowadays to have ovarian hyperstimulation syndrome. Just freeze-all for these high responders.
So what is your favorite drug for triggering these patients?
These patients, the high responders, GnRH agonist.
Yeah.
I only use this. Sometimes you can observe some patients with that they don't have an adequate number of oocytes retrieved, or that we perform the agonist trigger and we don't achieve the LH peak. And then sometimes it's possible to do the trigger, and then if necessary you can use HCG in low dose, but in general GnRH agonist for hyperresponders.
Okay. So are you experimenting with some combination permutations like analog plus HCG?
Yeah. For patients without the risk of OHSS, we really perform the dual trigger GnRH plus HCG.
Okay. So how much value do you give to AMH and how much to AFC while deciding the dose of hyperresponders?
I think that the AMH, the results of our AMH, they are incredible in these studies. However, when we go to our routine practice, sometimes the results you can trust on these results. And nowadays, with the protocols of antagonist protocols, we can evaluate the AFC at the beginning of stimulation. Thus, I prefer to use AFC. In a recently published study comparing to use an algorithm including AMH or just evaluating AFC, age and BMI, there was no difference in the results considering the poor response or an unexpected hyper response. So it seems that the AMH it doesn't add any benefit in selecting the dose for patients. If you have a result that really can trust on that result, it's interesting, and also to perform studies. But I think that in our daily practice, if the cost is not so it's not accessible, I think that it's not necessary to have an AMH nowadays.
All right, sir. So you've met so many doctors in India, and what is your take-home messages from here?
I think that you have wonderful clinics with good results, a huge volume of patients here, and sometimes depending on the number of IVF cycles that you have in your clinic, sometimes it's difficult to perform individualization. You have a lot of doctors, sometimes it's difficult to do that. But we really need to think about what is the objective of our patients. The objective is to have the delivery of a healthy baby And we can't just think in the beginning of the pregnancy. We need to think about safety and this delivery of a healthy baby. They must form the best for their patients. They must look for what is the best and discuss the thing with the patients. The patient nowadays, they need to have the option to select or also to have an opinion in their treatment. That's my.
All right, so thank you so much for sparing so much of time and giving your valuable
Thank you.
feedback.
Thank you.
Thank you so much.